Assalamu alaikum, everyone. My name is Lema Sibai. I'm a third year medical student, and I am more than excited to give you today or teach you today's histology crash course for GIT. Now, these are my contacts, and let's go right into the video. I hope to make this quick and easy in a cohesive learning opportunity. Anyways, let's start. So we're gonna go from the oral cavity to the esophagus, the stomach, small intestines, large intestines, pancreas, everything. We're gonna cover everything today, basically. But before I wanted to get into this, I wanted to say that, in my first year, I thought histology was like so boring and it's more of a memorizing thing. But now maybe this is different, but coming from a personal perspective, or yeah, my perspective, it was more of like a memorizing thing. And I wanted to really break it down in today's video, or today's session as more of an understanding kind of way. And the thing about histology, and it's so convenient that histology is really, really logical. And to some, you'll be like, oh, what? Or maybe not. I don't know. But I didn't think it was logical, but now I'm here to tell you it is logical. And I will try to explain the reason why, like the why behind everything. I'm not the kind of person that enjoys memorizing things and not understanding why I'm memorizing them, or anything like that. So I hope this is helpful for those who find understanding things easier rather than just memorizing them blindly. But I also wanted to mention something important that in histology generally, function follows structure. And so, for example, I'm just splurting over here, but like, um, for example, like squamous cells, they're usually for absorption or more for like tactile, pressure, mechanical kind of things like protection and just like it's that kind of thing. And so you would assume that in the places where it's going to be abrased or like hurt easily, there would be a lot. So stratified squamous or like columnar is for glands and like secretion and absorption, and it allows for that kind of like surface area, like increase of surface area. So everything follows a logical sequence. And inshallah, I'll try to break it down for you guys. Um, yeah, okay. So before we go into anything, we have to understand the basic layers of histology in the GI, because in some places it lacks a certain layer, in some places it has more of it, in some places it changes. And so this is a template. I'm giving you guys a template right now. There's a template. So it starts off with mucosa, submucosa, musculaire, subserosa, and serosa. And the most important part over here, in my opinion, is the mucosa because it's so subject to change. Submucosa and musculaires tend to stay the same. However, there are some exceptions. So I will be pointing those out. But mucosa is really important. Why? Because it has the epithelium. It has the lining. It has like, and the epithelium changes. The epithelium right over here changes. It's not always squamous cell. It's not always columnar. It's not always like, it's always different. And so this is really important. And another point to point out is that there are two kinds of muscle layers. There's muscularis mucosa, which exists in the mucosal layer, and there's muscularis externa, which is primarily the more force or like blunt movement muscle thing, in comparison to the mucosal one. So that's just something so important you have to keep in mind because it's not interchangeable. I don't know. I made a mistake. I made the mistake of like thinking it was interchangeable. I don't know what I was thinking, but just for those, we learn. It's good to learn now than learn in your exam and learn from your mistakes and everything like that. Okay, another fun thing that I did is I added this shiny, shiny star next to everything that I think is very, very high yield and very, 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 very important. And if anything, you know what, you can stop the video right now if you're in a time crunch, or maybe not. Maybe it's in your best interest to watch this. But everything I put a star next to this is worth reading through. It is so important. It can come in your exam and probably will. But this is just my what I think, not what I think, it's from previous experience and what I've seen in exams in general. If you catch my drift. Anyways, so let's start off with the first lecture, oral cavity, tongue, salivary glands, and yeah, let's move on. So, very easy. Let's move with how you would eat something. You start off with the tongue, not the tongue, the lips. And so very, very easy. Everything is stratified squamous. As I said before, stratified squamous because it's used as like a protective layer. If your lips were made out of, I don't know, like columnar, that wouldn't be very efficient. It's mostly just protective. Anyways, so these are the vermilion of your like lip, and it's mostly the pink part. And so the pink part, since it's pink, you would think that it has high vascularity. So it does have high vascularity. And another point to point out is that in your lips you don't have hair follicles. So just remember, there's no hair follicles, no sweat follicles, not sweat glands. Just keep that in mind. It's I wouldn't say like it's high yield or something you're going to be tested on, but it's kind of common sense. So think about it. In the skin above your lip, you would technically have hair follicles and sweat glands because you usually sweat or grow hair there. Anyone can. Anyways, this is all that this is. This is the stratified squamous that I told you about. This is the lamina propria, blood vessels, all that. And this would be the skin above the lip. So this would be probably the vermilion, so the pink part, and this would be the skin above it because there's a hair follicle. Okay. So next, once again, logic. Let's think about this logically. There's two kinds of epithelium when you go into the actual oral cavity, and let's identify the parts of the oral cavity. So there's the hard palate right over here. As soon as you open your mouth, you're going to see the hard palate, and there's the soft palate in the back. And you have your cheeks. So over here, your cheeks and your gingiva. So your gums, that's what gingiva are. So think about this logically. All of this is stratified squamous. The epithelium is stratified squamous. However, it's either keratinized or non-keratinized. And what does keratinized mean? Keratinized is just a protein like on top of the epithelium that protects the epithelium. So anytime I say keratinized, think of this needs protection or this area needs protection. And so when we talk about gums and we talk about the hard palate, these are typically areas where you eat and there could be, a cause for abrasion because you could eat something potentially like spiky or something harmful and it can get into your mouth and it can cause you to bleed if you truly don't have the right protection. And so coincidentally, we have lots of keratin in here and in our gums so we don't bleed or, it's going to, so just to protect it. And just remember soft palate and the cheek, as well as the bottom of your mouth. Usually those are the areas that don't really get the hard food that could abrase you or like could hurt you in any way because the soft palate is at the end of your oral cavity. It's very, very inside. And so by the time that you eat that, it's like the bolus of food. Like food is like when you chew it, it's like bolus. So the bolus of food would typically be chewed, it would be digested by the time it gets there, so it can be pushed down the esophagus. And so the cheeks, also, you never actually abrase your cheeks by eating something. Maybe you can if you're eating like a cactus or something, but why are you eating a cactus, right? And so just think about it like this. As well as the histology, blood vessels, all of that, very basic stuff. Okay, this is so high yield. This is so high yield. The tongue is so high yield. So, in the tongue, it's not just one tongue. You have a posterior segment and an anterior segment. And what differentiates or separates the two is something called the terminal sulcus. The terminal sulcus is right here. And this is 1/3 and this is 2/3. Okay? This is very, very important. And another important thing is to understand. Oh, and all of this is also stratified squamous. I'll explain more. But all of this, like the epithelium is stratified squamous. However, there are some projections. If you like stick out your tongue, you can see a lot of like tiny little hairs, and these are the tiny little projections that I'm going to talk about in 1 second. But just to give you like an overall view of the histology. Okay, another important thing is that don't mix up the dorsal and ventral tongue. When you are standing up in anatomical position, your tongue is not correct. It's like straight out like this, but that is not correct anatomical position. Think about it. If you could truly have ventral and dorsal, it would be a lot more confusing. So in anatomical position, you have your hands like to the front and you're standing upright. Typically, your tongue would be lifted up. It would be in the direction that the muscle is attached in. So it would be lifted up. And so if you're lifting your tongue up, the ventral side would be the bottom of your tongue right over here. And the side that we see, sorry, I shouldn't have done that. The side that we see the side that we see is the dorsal tongue. And so please do not mix up dorsal and ventral. Dorsal is the part that you see, ventral is the part you don't see, okay? Now, let's look at the muscle. Now, it's a fun fact. You always say like, oh, what is the only muscle in your body that's not attached at both sides or something like that? It's the tongue because it's a very interesting, muscle. Over at the end of the day, it is a really interesting muscle. It's visceral striated. That just means that you can voluntarily move it. It's not a smooth muscle. You don't just parasympathetically move your tongue, right? Like maybe you don't. It's not like the same way you try to like beat. No, obviously not. I'm sure you know what voluntary and involuntary means, so I don't know why I'm explaining it. But also, there's extrinsic and intrinsic muscles. Intrinsic just means you can change the shape, and extrinsic means you can change the way it exists in space. So you can move your tongue around, and you can also change it internally, like the shape of it. And I will not do that, but like you've seen a bunch of people like fold their tongue, and you can move your tongue in lots of ways. So that's an example of that. And also, the muscle is like pulled and like assorted in like a bunch of random ways because it's not meant to do only one thing. It's meant to move in whatever direction you want it to move. SubhanAllah. Another point is that there's adipose tissue in the t in the tongue. As you can see, these are all the striated muscle. They're all like assorted in random ways, oriented in all directions. And there's adipose tissue. Now, something interesting that I think is really cool and may take a little bit of time, and you can skip this if you want, but there is something called like obstructive sleep apnea, and it happens to very obese people. And the thing about it is when you are obese or like when you gain weight in the already existing adipose tissue parts in your body. You have adipose tissue everywhere. That doesn't necessarily make you obese, but it makes it like it exists. And so as you gain weight, it gets bigger wherever it exists. So the interesting thing about the tongue is that if you are obese, your tongue gets bigger as well. And the thing about obstructive sleep apnea is that once your tongue gets so big, once you sleep, it actually obstructs your airway and you begin to suffocate and get hypoxic in your sleep. And I just thought that was a really cool clinical correlation. And so you'll forever think, wow, when on a tongue histo slide, there will be adipose tissue, and you know why now. Also, it allows for like cushioning. Like there's a reason why your tongue is so like squishy. It's not like some stiff, hard, rigid muscle. Okay. Now, when you look at your dorsal part of your tongue, which is the part we can actually see, it's you know how I talked about the little projections? They're called lingual papilla, and there's lots of different types of them, okay? And these are the different types of them. And they're distributed all throughout here, and I'll go through them right now, but specifically in the dorsal place, not everywhere. It stops right over here. And what was this called? The terminal sulcus, right? And I'll explain, where these all exist. Now, the first one is filiform papilla, and this is probably the most important one and the most iconic picture ever, because you will see this not only now, you will see this in your board questions, you will see this in GIT later, you will see this in this is a very iconic slide because once you see this, you know exactly what this is, unlike a lot of histology slides, which are kind of confusing. Now, the thing about this is that, what did I say? Keratinized. What does keratinized mean? That it needs protection, it's extra protection. But in this case, it's specifically used for friction of the food. I'll explain right now. On the tongue, it's the most numerous. It does not have taste buds. Now, a lot of these lingual papillas and the rest of the lingual papillas do have taste buds. This is the only one that does not have a taste bud. And remember, this is so important and so high yield, and you will probably get tested on this. And I'm telling you right now, remember it. But it's the most numerous, does not have taste buds, and it also has like a keratinized tip right over here. You can see like the keratin is like kind of floating over here. It's like loose and it's all at the tip. And this exists to hold on to the food, to hold on to the bolus of food so it doesn't slip down your throat. So that is the most important part. And it kind of looks like a cone. You can remember that. Now, fungiform papilla, this is the second most numerous type, and this is just spread within the filiform, which was before, but the most important part about this is that this has taste buds, unlike the filiform. It has taste buds, and it kind of, I don't know, they say it looks like a mushroom, but I guess it kind of does. I don't really know. Anyways, now this is so important, and look how many stars I have next to this. So important, such an important slide, guys. Circumvallate papilla. And remember how I said that there's an anterior and posterior part to the tongue? Now, circumvallate papilla, it lines the terminal sulcus. It lines it. It's the part where it distributes like kind of the anterior and posterior part. So when you think of terminal sulcus, the circumvallate right over here, they're gigantic, they're ginormous, and there's about like 8 to 12 of them, and they're lining the sulcus. Okay. And the thing about this is it kind of looks like a dome, I guess. It kind of looks like a dome, I guess. It has a hat on now. And the thing about this also is that it has invaginations. And if you look at this, it's not really invaginated. It's a papilla, like it's a projection. However, it's not truly invaginated. And circumvallate, circle, it almost does look like a circle. Look how round it is. And the most important part is that it has taste buds. Just like fungiform, it has taste buds. Circumvallate papilla have taste buds. And an interesting thing about this is what is its point? Like, what is the point of a circumvallate papilla? You know when you eat something and then like you're done eating and then 15 minutes later you can't really taste it anymore? That is because of your circumvallate papilla. And you know, the reason why it does all of that is because it drains everything into these glands of von Ebner. This is so important. I have a star next to it. And if you didn't have, like, if there was a congestion, if you didn't have them, you would still retain the taste for a very long time. You would not clean your palate. And how annoying would that be? SubhanAllah. Okay, next. Ooh, folate papilla. I'm not going to spend like 1 second on this. Humans don't have it. It has taste buds though. It has taste buds. What was the papilla that did not have taste buds? Filiform. Okay, this is kind of like it's considered, it's no, we don't have that many. It's mostly in animals. Okay, now, as I said before, fungiform, circumvallate, foliate have taste buds, very important. Now, what the heck is a taste bud? Excuse my language, but what is a taste bud? These are taste buds, and they kind of look like onions, and they're always at the lateral sides of the papilla. And by the way, just for your information, this would be all stratified squamous, and this would be the lamina propria, and then there would be like these glands, and then there would be like muscle over here, and this is how like the muscularis mucosa over here, and this is how it'd be distributed. So this is still epithelium. It's just projecting into it. It's not columnar. This is not columnar if you get confused. But along in the epithelium, inside of it is shoved a bunch of taste buds. And there are little like pores, and they're called taste pores. And like through that, when you eat the food and there's chemicals and it creates a reaction, it goes through these pores and it, signifies to this cell that, you're tasting something. And we have like a bunch of tastes like umami, bitter, sweet, salty. You know this. I'm sure everyone knows this. Now let's go into details, which are the sensory. They're innervated by nerves over here. And the nerves come up from here, afferent nerves. So afferent means coming, and efferent means leaving. So afferent means that it's receiving information. And then if it was efferent, it would be also leaving. Okay. And they also have microvilli at the apical part, assuming to like increase surface area. But this could be the facial nerve for taste in the tongue. Typically, it is the facial nerve. I think anterior 2/3. I forgot my anatomy. But I would assume, I think from what I remember. And as well as sensory and supporting, there's basal cells. And basal cells are just stem cells. They differentiate into sensory and supporting cells because there's a lot of cell turnover. Your taste buds don't last forever. And this is all you really need to know. And this is how it looks like on histology. So the light ones, the pale ones are sensory. As I said, I pointed at it correctly here. And then the supporting ones are the more darkly stained ones over here. And then the basal ones are like, I guess they're the ones that like differentiate at the bottom. And then the nerves run over here and innervate through here. It's the taste bud. Okay. Now, we talked about the anterior dorsum of the tongue. Now, the posterior. The posterior, all you really need to know about it is that there exists lingual tonsils, and they're so obvious. These are not papilla. It does not have papilla. These are tonsils. And these tonsils just have follicles, like lymphoid follicles, as you can see over here. Stratified squamous, as I said before, stratified squamous, and these are the lymphoid follicles, and these are just tonsils, and they exist for lymphatic purposes. Okay, now the ventral of the tongue, just remember, the ventral of the tongue does not have any papilla, does not exist to friction any kind of food or taste any food. It just exists for, protective reasons. So it's stratified squamous. Now, yeah, and you can't really tell if this was any other organ that had stratified squamous as well as like submucosal or something. Okay, so salivary glands. There exists three that we need to talk about. These are all capsulated, so they all have a capsule. Okay, now, when it comes to saliva, what is saliva? Saliva, there's about 800 to 1,200 milliliters. It's basically, we produce a lot of saliva, and it's because of these three organs, and submandibular produces the most. Now, the functions of saliva, obviously to lubricate the oral cavity, if anyone's had a dry mouth, it hurts to like swallow, it hurts to eat, it hurts to talk, it hurts to do anything. So, it helps to lubricate the mouth, as well as antibacterial. There's a lot of bacteria in our mouth, and there exists lactoferrin. And lactoferrin honestly just binds to iron. And the interesting thing about iron is that bacteria love iron. These are the bacteria. Bacteria love iron. And so when lactoferrin binds to iron, it can no longer have iron in the mouth for bacteria to cultivate. And so that's how it's antibacterial lysosomes. It also exists to take down the bacterial cell wall. And this is secretory immunoglobulin A. And immunoglobulins are just antibodies against any kind of antigens that can, invade the mucosa. And then digestive, it's very digestive. Like, and you might think that when you're chewing, nothing's actually happening, but you're also digesting the food. So amylase, it exists to just break down starches into more simple, like sweets, or not sweets, like sugars. And then lingual lipase exists to break down fat and I think protein. Okay. Now, glands. Glands exist in two forms, exocrine and endocrine. Exocrine, there's a obvious duct. So a bunch of things are being secreted here and it's being let out through a duct. Endocrine, you learn this more in your endocrine block or endorepro. But it's secreting, and it's secreting directly into the bloodstream or secreting into nearby cells. It's not necessarily through a duct and through like ducts and the duct system, and it doesn't come out like that, no. And it's more with hormones and things like that. So to explain glands, basically simple means that it's just like a straight thing, like it's, coming out one way, and then compound is a bunch of simple glands together. And there's types of secretory units, and these are categorized by shape. So tubular looks like this, and acinar looks more like circular. It looks like this. And so all you really need to know, simple tubular looks like this, branched, it's multiple. Don't tell me this is compound, because this is still like a bunch of things connected together going into one duct. And this is also simpler acinar, and then simple branched acinar. Okay. And then compound, it's a bunch of branched tubular or tubular acinar, because there can be mixed. It can be tubule and acinar together. And this is essentially how it looks like. It's not really that important, but it's good to keep in mind. Now for salivary glands, whatever. There's a capsule, like I said before, and this is the really thick capsule, and it divides the lobes. There's lobes, and this is what we just talked about. Like we just talked about the acinar and the ducts and all of that, and the capsule divides it into like septa and lobes or something like that. And yeah, this is all this is. And okay. And he kind of said that it was like a grape, and I agree, but there's different kind of like acini. And acini just means secretory units, as I said before. Like there's yeah, as I said before. Now, serous acini, it exists to produce protein. And inside of these, there's lots of endoplasmic reticulum to produce the proteins, okay? And more importantly, it's shaped like a little pyramid, and at the apex, it's like a little pyramid at the top of the triangle. There's a bunch of granules, and the granules just secrete zymogens. And zymogens could be anything. It's not specifically protein secretions. It could be mucus. For serous acini, they secrete protein, but in granules in general, I'm saying that they can produce like mucin or or protein. And they have a wider bottom, and it's kind of like oriented like this. And so all of them would be like this. The granules would be at the top, and they would be secreted into the duct over here, and the duct would have a longer ductal system. Okay. Now, there's also mucus acini, and this is a little bit different. This is very important, that the shape is different. Over here, it had a round central nucleus, and it was darkly stained. And over here, the nucleus is kind of like squished at the bottom, at the base, and there's a lot of mucus granules at the top. Okay, so these are the mucus granules, and there would be the nucleus down over there, and this would be the duct or the lumen or wherever it's going. And all that it does is it just secretes mucus. Now, there's mixed acini, and over here, they're just talking about the fact that, like, when you're doing a pathological slide, you can't preserve the tissue in its full essence, right? There's always some problems, or there could, this is how it happens. So there's mixed acini, which is serous and mucus. And so another way that it can form or develop is if it's like the mucus is like this, and there's something called serous demilunes, and demilunes like lunar, like half a lune, so half a lunar, like half a moon. It kind of looks like this. It's like hugging the mucus. Yeah, acini. And then this is a more important concept. Over here, there's also typically myoepithelial cells, and the myoepithelial cells just contract um, to, push the secretions into the ducts. So we talked about all of this, but there's a ductal system. Like, how does it actually get out? Um, we're still in the salivary gland, and like, how does it actually get out into my mouth? All of this, it's not produced directly into my mouth. And so once you leave the acini, you go into a ductal system, and you start off with intercalated ducts. And intercalated ducts have cuboidal cells, and this is really important. You should remember this. And all they do is they just, like the main function of the cuboidal cells are to push bicarb and absorb chloride, and this is just to neutralize the bolus of food just to go down the esophagus. And then also for the striated duct, it comes after the intercalated duct, as you can see here. The striated duct gets its name because it looks striated, but it's actually it just has tiny little microvilli protruding, and it's more of like columnar, cuboidal, but it's mostly columnar. And it also does the exact same thing. It pushes in bicarb and potassium, and it, absorbs sodium. And the excretory duct is something we're going to talk about here now, but just relate this to the fact that there's a lobule. And so right now we are in the lobule, like we talked about the lobule, but this is now we've gotten out. And once you get out of the lobule, you are in now like a territory called interlobular. And that means between lobes, like between the lobes. And between the lobes, the epithelium is pseudostratified columnar. This is really important. And you have to remember these. And once you get into the main duct over here, it's stratified columnar. Okay? So once you're outside and it's interlobular, it's pseudostratified columnar. And then in the main duct, it is what? Stratified columnar. Okay. Now we're going to talk about the glands in specific. Now, a very important primary point that you need to remember is that these glands, I'll explain over here more. So these glands, they have specific, they all look different, okay? So parotid gland, it has the longest and most obvious striated and intercalated ducts. As you can see here, they're so long in comparison to over here. It's still pretty long, but not as long as in the parotid. And over here, it's like the acini takes up most of the space, okay? And what's it called? Wait, yeah. And then over here in parotid, it's usually primarily serous acini, and then in submandibular, it's also serous acini. However, it can also have mucosal, mucus acini, but in sublingual, it's completely mucus. Mucus, mucus acini. And another point to point out is that it has poorly developed intercalated and striated discs. You're probably like, why should I care about that? Well, it's an interesting fact because since it's already primarily mucus secreting, and this intercalated and striated discs exist purely to like push in bicarb and take out the acidity, why would it need to do that? It's already in an alkaline position. And so that's something really interesting. And so now we can look on like histopathology. As you can see here, it's a lot of serous acini. It's a large central like nucleus. Just remember that there's a lot of adipose tissue as well. And then over here, come on, it has a lot of serous acini. And over here, it's primarily, as you can see over here, the mucus acini. And it's so much. Like there's only a little bit of serous acini. There's more mucus acini. And over here, there's mucus acini as well. So you can remember a serous acini mixed and then entirely mucus or mostly mucus. Okay, now we're done with the first lecture. Let's read out the questions. A patient has inflammation localized to the V-shaped region of the tongue near the sulcus terminalis. Which papilla are most likely affected? The answer is circumvallate. This is very important. I said that circumvallate lines the terminal sulcus, okay? Which gland is characterized by poorly developed intercalated and striated discs? Do you remember this? Sublingual. Like I said before, it doesn't need intercalated and striated discs. It is primarily mucus secreting. The dorsal surface of the tongue, which is the part we can see, is examined at high magnification. Now, as I said before, what does this look like? I want you to, okay, what does this look like? And now what's the purpose? I'll give you a second. D, surface for food and movement. I would have gotten really mad if you said anything else. But it does not have any taste because how many times did I stress that filiform papilla have no taste buds, so it cannot taste anything. Also, pain receptors isn't something we talked about. Now, the parotid gland is examined at high magnification, identify the structure indicated by the arrow. Serous acini. As I said before, round central nuclei. You don't even need to look at the histo. As soon as you see parotid gland, it's mostly serous acini. It is usually never mucus acinus. Okay, now we can start with esophagus and stomach. So, bismillah. Ooh, bismillah. Before we start, we have to revise, once again, the layers. In the stomach or in the esophagus, there's what's it called? Epithelium, and then there's lamina propria, muscularis, mucosa, and all of this is all the mucosal layer. Okay? And then there's submucosa, and then mainly the muscularis externa. And this is histologically, the muscularis externa is over here. This is all the lamina propria, or not lamina propria, submucosa, and then over here would be the mucosal layer. Okay? Now, let's split the esophagus in half. And to understand histology, you have to understand where you are. I can't just tell you, what's this? Because you won't know what this is unless I back it up and I tell you this is what this is. Now you can really analyze what my hand looks like. Okay, we're going to flip it around and we're going to analyze this part of the esophagus. Just keep this in mind when I build a picture that I'm specifically talking about this orientation of the esophagus, okay? Wait, sorry. Okay, now, first of all, we're going to start with the mucosal layer. And for the esophagus, just think about it. It's a conduit. It's a pathway for the food to get down from your mouth to the stomach. And so it doesn't have to, its main job isn't absorption or anything fancy like that. And so it'll stick to stratified squamous. And so for here, it's stratified squamous, and there's a bunch of layers for protection, for any abrasion, because you could, eat something that's like spiky, injures your esophagus, so it has to be thick, right? But not keratinized, mostly because you're not going to eat a lot of spiky, hurtful things. So naturally, it's stratified squamous to keep it at a baseline protective mechanism. And then the mucosal, what's it called? The lamina propria just has the blood vessels, lymph nodes, and loose connective tissue. Muscularis mucosa, just longitudinal muscle. And then we move on to the submucosa, and this is pretty important. It has dense, irregular CT to, hold maybe what's it called? Keep its integrity. And there's also blood and lymphatic vessels, and this is very important. In the submucosa, anywhere in the GIT, there is something called Meissner's plexus. And besides parasympathetic, sympathetic, all of the, CNS or central nervous system or peripheral nervous system idea that you have about neurology in general, there exists a plexus in the submucosa, in the GI, very important, and it's called the Meissner's plexus. And this helps with peristalsis and whatever else you need to do. And there's also esophageal glands, and this is to lubricate the esophagus or whatever else it needs to do. Also, they are primarily in the beginning and at the end. And I don't know if you guys know anything about a GERD or gastroesophageal reflux disorder, but briefly, if you have a lot of acidity in your stomach and your stomach is it's directly attached to your esophagus, it's going to bubble up and it's going to start attacking the esophageal epithelium. And so what I'm gonna teach you now is that the stomach does not have the same epithelium as the esophagus. So the esophagus cannot handle all that acidity. And so why this mucosa, or why this mucin, or what's it called, mucosa in general, it's high in bicarb, and it's high in it's an alkalining agent, or it's an alkalining agent, and it basically coats the surface of the esophagus to allow for, protection from that natural acidity that we get. GERD is a more pathological, it's a disease, but naturally we do have acidity like rising up to the esophagus. So we do need a lot of mucus at the end of the esophagus to really protect our epithelium, okay? Now, this is really important. I have 2 stars on this, so please, please, please pay attention. In the esophagus, think about it. You're eating something, and until here, you swallow, right? You swallow and you go, "Ooh." That was like me trying to swallow, but you have some control or voluntary control up until a certain point. Now, the esophagus is split up into thirds. There's a third that's striated, and we can control that voluntarily. And there's a third that's mixed, so voluntarily and smooth. And then at some point, once you've eaten your food and you've swallowed, you don't voluntarily swallow the entire time. You're not voluntarily doing peristalsis or, pushing the bolus down your esophagus. So just remember that in the upper portion, there's striated and then mixed and then smooth. Now, the muscularis mucosa in the esophagus, there's two kinds of muscles. On the outside, there's a longitudinal muscle, okay? On the outside of the muscularis externa. Muscularis. Yeah, this is muscularis externa, not to be confused with muscularis mucosa. I don't know why I said that, but it's longitudinal muscles. And then between that, or like the other muscle, is circular muscle. And this is just, it helps in peristalsis and pushing down the food down your esophagus, right? It's propelling it. Okay. And between those two, and this is so important, once again, between all the circular muscles and all the longitudinal muscles, there will always be something called Auerbach's plexus. Okay. And this is to stimulate peristalsis and to really like what's it called? The more neurological, or what's it called? Yeah, it's basically to stimulate peristalsis. I don't know what else I could say about this, but this is a very specific plexus. And so when I say Meissner's plexus, where does that exist? Submucosal layer. Like I said before, submucosal layer is Meissner's plexus. And in the muscularis externa, it is Auerbach's plexus. Perfect. Between the circular and longitudinal muscles. So important. Okay. And lastly, there's adventitia. And towards the end of the esophagus, it's serosa. Adventitia is just used as like more to hold in the esophagus in place. And at the end towards it, once you get to the stomach, it's covered in serosa. Okay. Because your stomach is an intraperitoneal organ. So maybe I feel like if you studied anatomy, you'd understand what I'm talking about, but just for the sake of this video actually being short, I'm not going to go into that, even though I really want to. Okay, so the stomach. The stomach isn't just the stomach all around. It's not the same thing over and over and over in the same epithelium. No, the stomach is divided into parts. The stomach, so first of all, this is the esophagus, and this is called the cardia. The cardia is basically the junction or the part where it connects to the stomach. And this is the fundus. The fundus is like a straight line from the esophagus, and it's just the head, and this is all the body. And the pylorus is kind of the end of the stomach. And then after the pylorus, after the stomach, is the duodenum. And in the stomach, to increase so the point of the stomach is that it has to absorb and secrete, and it also has to expand. A very interesting thing about the stomach is that it expands, right? So when you eat and you feel bloated and your stomach is bigger, that is the doing of rugae. And rugae is over here. And rugae is like projections the of the layers through, and it kind of makes like a little finger-like projection. And so over here, this is the submucosal layer, and the submucosal layer pushes its way through the mucosal layer, and it creates this rugae. And the point of this is called a temporary fold. Now, I say temporary because you may be thinking, is there permanent folds? Yes, there is. And so I want you to remember that this is a temporary fold. Rugaes create temporary folds to allow for expansion. Okay? And there's a lot of loose connective tissue in the submucosal area over here. No, there's a lot of in the lamina propria that I don't know what I was talking about, but it just allows for temporary folding so that you can expand the stomach when you eat a lot of food. Okay? And there's simple columnar all over here. We'll explain more of that later. And yeah, as I said before, the esophagus goes from being stratified squamous to simple columnar. And the simple columnar have little microvilli. And I wanted to explain it over here that this is submucosal, and then this is the epithelium, and it's pushing through. And this is the muscularis externa. Okay? Yeah. Okay. So the stomach, as we said before, has the cardia, fundus, pylorus, and they don't have the same gastric glands. And over here, there's something in the stomach. The most important part about the stomach is that it's secreting and absorbing, and secreting and it's absorbing. And this is what the glands look like. I'm going to zoom in over here. So as I said before, this is the muscularis externa, the submucosal layer. It's it's pushing through the mucosal layer that's already existing here, and we'll explain more about that in detail now. Okay, so this is the gastric glands, and the gastric glands are contain a lot of kind of cells. They don't just contain one kind of cell. And I'm going to explain this to you right now. They have all these cells: chief cells, mucus cells, parietal cells, enteroendocrine cells, and stem cells. Now, to start off with mucus cells. Now, mucus cells are found on the lining over here, over here, over here. Okay, and the job of the mucus cells, they're simple columnar, first of all. They secrete mucin, as I said before, and their job of it you know, isn't to neutralize the acidity, it's mostly for protection. And so it's secreting mucus. As I said before, it's high in bicarb and potassium. And these are two alkalining agents against acid, not alkalining agents, but it just protects the endothelium, all of the endothelium over the stomach, the endothelium of the stomach, and it protects it from the acidity, the harsh acidity of the stomach. Because like if we didn't have any kind of protection from our own stomach that can literally like dissolve itself, it can eat itself, then what are we going to do? And so it kind of lines the entire stomach as well as the gastric pit. And the pit is just the opening place. Okay. And so as I said before, it's high in bicarb and potassium. This is so important. It protects the mucosal surface. And also, a fun fact about this is that prostaglandin 2, it increases mucus secretion and increases bicarb. And so this is just it's an inflammatory mediator. I don't know if you took leukotrienes at this point, but it increases mucus secretion and bicarb. So when you have an increase in prostaglandin 2, and I think you took this in physiology, there are some things that induce producing prostaglandin 2. But okay, and the clinical link here is that NSAIDs, which stand for non-steroidal anti-inflammatory drugs, you take them and all they do is they decrease the secretion or the production of prostaglandins E2. And all this does is it just decreases the mucosal layer and you're more prone to bleeding because without your mucus and without your bicarb, you're going to bleed because how else is the stomach supposed to protect itself? Anyways, there's also, besides the mucus cells that are found on the lining, there's also some in the neck of the gastric gland. So this is like the whole thing, and there's the neck, and it's just yeah, it's just there's some found just to alkaline the whole, like there's a bunch of other cells here that produce some things, and yeah, that's all you really need to know, that there are some that are found at the neck of the gastric gland. Okay, now we can talk about parietal cells. And parietal cells are so important. You know, I'm a third year and I'm taking GIT and I still talk about parietal cells. You're never going to escape them. But essentially, they look like this and they're humongous. And they're binucleated. And they also have a lot of mitochondria. And that's important for ATPase production. Because why? I'll tell you right now. Because parietal cells they produce HCl. And HCl is pumped out here through an important channel that you probably took in physiology, and it just uses ATPase as, the currency of exchange at the pump. Anyways, what HCl does, however, this is very, very important. I have a star next to it. It activates pepsinogen and turns it into pepsin. And you may be like, why does this matter? And I'll tell you now in a bit. But pepsin essentially just increases the acidity of the stomach, and it's a bacteriostatic. And also parietal cells, this is so important, they produce intrinsic factor. Now, this is a very important clinical link that you could totally be asked on, but intrinsic factor, it helps with the absorption of a vitamin called B12. And I'm sure you took this before, but it's used in like fetal development. You'll take this later on. But vitamin B12 is very important to us. And if we don't have vitamin B12, we end up with something called pernicious anemia or megaloblastic anemia. And this is how you would end up with a lack of intrinsic factor. Usually, autoimmune diseases, if you don't know what autoimmune means, it means when your body attacks your own cells, right? It doesn't recognize your own cells, so it starts attacking them. And they attack these parietal cells, and these parietal cells can no longer produce intrinsic factor, which is so essential in absorption of B12. And that's all you really need to know from this. Okay, now chief cells. Chief cells are pretty important, and I don't think, okay, yeah, these are what chief cells look. They're stained a little bit darker than parietal cells. Parietal cells are a lot lighter, but they have rough endoplasmic reticulum. Why? Because they produce, what's it called? They produce I'm assuming protein, but they produce zymogen granules of pepsinogen. And pepsinogen, as we just said before, what activates pepsinogen? And pepsinogen is an enzyme. It's an inactivated enzyme. So once you've activated it, it turns into pepsin. So pepsinogen turns into pepsin after HCl is produced by parietal cells. Chief cells and parietal cells work in sync. Okay? They work in sync to increase the acidity of the stomach. And this is very, very important. It has a star next to it. And yeah. Okay. And as I said before, these are what we're looking at. And these are all, by the way, these are all glands in the fundus of the body. We're not talking about pylorus or the cardia or anything I just talked about. We're talking about the fundus, so the main body of the stomach. Okay, now we're going to talk about stem cells. And the stem cells are in the isthmus. This is very important. I have a star next to it. So when Lema asks you, where are the stem cells in a gland in a fundic gland found? Isthmus. This is so important. And all they do is they just differentiate into either mucus cells or down they turn into parietal cells. It's just differentiation. And over here it's really cool because they caught like mitosis on camera. And so they're pointing it out, saying, look, we found stem cells. Okay, now pyloric versus fundic, and this is very important. Now, as I said before, where was the pyloric part of the stomach? It was towards the end, right? And so the stomach is a really, really acidic place. And the point of pyloric glands, they are so full of mucus secreting glands, that the whole point of it is that they need to calm down the acid or protect the duodenum or the small intestine from getting destroyed and getting hurt by the acidity from the stomach. Subhanallah. And so this is why pyloric glands, they are way deeper than fundic glands. As you can see here, they're kind of more shallow. They have so many more mucus secreting glands to protect the intestinal or small intestine. Okay? Now, we're going to go one by one. The mucosa, it's simple columnar, as I said before, and they have the lamina propria has reticular fibers and fibroblasts, and it's more of an immune it helps with immunity because typically when you're trying to secrete a lot of acid, there can be inflammation, and so you need a solid immune system behind the epithelium to make sure that if there is any kind of inflammation, there's someone to back it up. And then the smooth muscle, probably with peristalsis in the stomach as well. And what did we say before? Meissner's plexus is found where? In the submucosa. It's also found here. And lastly, this is so, so, so high yield. The stomach does not have only two layers. Before, we talked about the esophagus. It had circular and longitudinal. However, the muscularis externa in the stomach has three muscles because it's so important to move the food around. So it has oblique muscle, circular muscle, and between circular muscle and longitudinal muscle, what did we say existed? Auerbach's plexus. So the stomach is the only place with three layers of muscularis externa, or like an external muscle area. Okay. Now, we discussed, now this is pretty important. Now, the pyloric sphincter, all you really need to know about this is as you get closer, the circular muscle thickens to, make the sphincter itself. A sphincter is just a thick ring of muscle. And yeah, and also the serosa, as I said before, the serosa that covers it, it goes on to create the lesser and greater omentum, which I assume you know by now. And now, there's the gastroesophageal junction. Oh, this is so important. It's important for you now. It's important for me. I'm gonna get tested on this, guys. Don't worry. You're not here alone. I'm here with you. Gastroesophageal junction. Let's see over here. I'm going to explain it in simple terms. What is the epithelium over here? Stratified squamous, right? And what is the epithelium over here? It's simple columnar, as you can see, like the little projections over here and the rugae and everything. This is literally the junction between the esophagus and the stomach, okay? And what's so high yield here is there is something called Barrett's esophagus. And it is really important because when there is enough acidity, as I said before, you have natural acidity that's being splashed into the esophagus, and your esophagus has to kind of like come back and be like, oh, it's okay, I have lots of mucus. But in pathological or, illness, when it's too much, your esophageal epithelium quite literally changes from stratified squamous, which is over here, to simple columnar, which is insane. it literally changes to adapt to the acidity of the stomach. And this typically happens if you have hyperactivity of acidity, if you smoke, if you drink coffee too much, if you're very obese. You're gonna learn this more in third year. I'm like ranting, but very important clinical correlation. Whew, we're done. We're done. Okay, let's start with questions. In Barrett's esophagus, the epithelium changes from, I just talked about this. Stratified squamous to simple columnar. Yes. The lining of the stomach is protected from the acidic pH buffering activity from HCO3 present in the layer of mucus covering the stomach lining. Which of the following cells secrete this protective ion? Okay, now we're going to talk about small intestine and pancreas. Now, the small intestine is made up of three parts: the duodenum, the jejunum, and the ileum. Now, these three parts they have mainly different functions. The duodenum is usually for digestion, the jejunum is mainly for absorption, and the ileum is less for absorption, but also partakes in absorption and more for immunity. Or secretes immunity, it's associated with immunity and mucosal secretion more. Okay. So the small intestine, once you go into the small intestine, there's something called circular folds. It has a specific name I'll explain now. And then in the circular folds, there's something called villi. And villi are projections through the mucosa and submucosa. And it has all these little things. And inside of the villi, or lining the epithelium, is simple columnar with microvilli. And just imagine, I'm telling you that the small intestine is usually for digestion and absorption. It's maxing out its surface area. And so when I show you, wait, hold on, this picture, there is so much absorption. It's like times 1 billion, because of how many microvilli and villi there are. And so imagine the amount of space you have to digest whatever, vitamins, fats, anything you need. Anyways, so these circular folds are called plicae circularis. What's it called? Wait, hold on. Yeah, circularis. Plicae circularis. And remember how I said in the rugae, it's a temporary fold because it's used to extend the stomach. Now, the small intestines aren't extendable. Their main goal isn't to extend, it's to absorb. And so as you can see over here, there's like still projections, but there's so many villi that are coming off of these projections along with the simple columnar that's lining all of these. It's so difficult to actually extend it. So this is what you call a permanent fold. It's not meant to extend. It's meant to max out its absorption. And yeah, it's a little bit more rigid. And both of them like project into the mucosa and submucosa. However, this is more rigid. Yeah, and plicae circularis is most likely or more commonly in the jejunum, mostly because the jejunum, as I said before, is the primary spot for absorption. When the food or the chyme comes in from the chyme is like the acidity with the food and the bolus, and this is what it's called. The chyme comes from the stomach to the duodenum. Usually the duodenum is breaking it down instead of actually primarily absorbing it. Okay. So villi. So once again, they're projections of the mucosa, and they have simple columnar with microvilli. And a very important thing is that in the middle of this, over here, there's something called a lacteal, and a lacteal is mainly used to absorb fats. And fats, the thing about fats is they cannot be absorbed normally through capillaries or like blood vessels because they're too big, right? And so there's an extension of the lymphatics called lacteal, and it's this green thing in the middle, and it's this like empty place here. And just remember, it's empty. Why? Because what is empty or what is clear on histostaining? Fats. And so it ends up being clear, or it doesn't actually stain anything because it's mainly used to absorb fats. Okay, so now there's glands, and there's what's it called? These are the villi, and an extension of these villi are crypts, and these are called crypts of Lieberkühn, a German word. And these crypts are usually for what's it called? Secretion. These crypts are for secretion, and this is called crypt of Lieberkühn. And this is very important that it extends into the muscularis mucosa. And so I said that the submucosa and the mucosa are pushing through to form the villi, and so the crypts are pushing through into the muscularis mucosa. And they have stem cells to regenerate and all of that. But the crypts are not usually longer than the villi. If they are longer than the villi, there would signify a problem, um, with the small intestine. Okay, so there's lots of cells in the intestines or the small intestine, but we're going to specifically talk about enterocytes. Entero means intestine. Enterocyte means intestinal cell. And so enterocytes look a lot like this. There's microvilli, and amongst the enterocytes, there's something called goblet cells that we will discuss now. But basically, it's simple columnar, and this is exactly what was lining what we were talking about before. And what they do is they just absorb fat and glucose. As I said before, they are mostly to absorb the vitamins and nutrients that we eat in the small intestine. Okay? And this is really important. And enterocytes make up most of the small intestine. Okay, goblet cells. Goblet cells are used to secrete, okay, I said goblet, goblin, I don't know. They're used to secrete mucus, and this is just to lubricate and allow for clear passage through the what's it called? Through the microvilli and through the villi and everything like that. And by the way, the reason why there's circularis, like the little folds, is because it wants it like the small intestine wants to build an environment where you fully go around, and it touches every single part of the mucosa to be able to absorb whatever it can, okay? And so that's why it's slow. It's not some slippery slope and there's nothing there. It's meant to really take its time. Anyways, the goblet cells also have mucus granules, just like the mucosal acinar cells that we talked about before, and it's kind of described like a flask appearance. Okay, so now Paneth cells are so important. I put like 3 stars, and that's the most stars that have ever been in like one slide. But Paneth cells, what are they? At the end of our crypts of Lieberkühn, there's something called Paneth cells right over here. And what they are is they just secrete, they're for immune purposes. They secrete defensins, they secrete lysosomes, and all of these are, bacteriostatic, and they fight against any kind of invasion or antigen or anything like that. And it has a hand in what's it called? Immunity. Why? As we get closer to the colon or the large intestine, the ileum is getting quite close to the colon at this point. And the ileum is like the last part. What's it called? You get closer to a lot of bacteria, and the colon is a like a landmine of bacteria. And so you need any kind of protection from the mucosal surface or from the like to protect the epithelium, the mucosal surface, all of that. And so Paneth cells exist to secrete what's it called? Just any kind of bacteriostatic or anything that fights against like innate immunity, basically. That's all it is. And as you can see here, this is what they look like, and everything's important here. Okay. Now, okay, yeah. Now, there's something called M cells or microfold cells, and they lie on top of Peyer's patches, and you don't know what that is right now, but I'll explain it later, inshallah. And they're also mainly found in the ileum, and they also play a part in innate immunity. So the ileum plays a big part in immunity to protect our body from the bacteria that, basically lives in the colon. So this is all it is. And now we can just explain it quickly here. As we can see over here, the epithelium lines, it's simple cuboidal with microvilli. It's the lamina propria and the muscularis mucosa, and it exists over here. And this is the lacteal, which is probably the most important part. And everything else is kind of, normal. And this is a really nice picture. Okay. Oh yeah, the lacteal is like empty, as we saw before. Okay, now we're going to talk about the submucosa. And this is very important, and this is why I have a gigantic star next to it. Only in this place do these glands exist. In the duodenum, Brunner's glands exist. It is unique to the duodenum. So when you say Brunner's glands, when you see Brunner's glands right over here, you know you're in the duodenum. You don't even need to check. This is the only place in your body that you have this. And Brunner's glands just they alkaline. They make the environment more alkaline and favorable to the pancreatic enzymes that come in. Because you know how what's it called? The pancreatic duct goes into the duodenum, it mixes and everything like that. But yeah, it just increases the pH. Okay, now there's GALT. And what is GALT? It's gut-associated lymphoid tissue. And GALT, it consists of Peyer's patches. Remember what I talked about? What lies on top of Peyer's patches? Microfold cells, yes, M cells. And these are Peyer's patches or the GALT lymph-associated lymphoid tissue. And all you need to remember is that It's mostly in the ileum. Why? Because there's a lot of bacteria. We need a strong defense or immune system. And over here, once again, the muscularis externa, it has circular and longitudinal as well as the Auerbach's plexus that exists there. Okay, now I'm going to test you. How does the villi look from the duodenum to the ileum? Okay, so the thing about the villi is that the duodenum, we said that it digests the most, and towards the ileum, it's more immunity centered. And so as you go from the duodenum to the ileum, the villi get smaller and thinner and deeper. And so that's the answer. And so where did we say that Brunner's glands exist? Only in the duodenum. It exists nowhere else. Peyer's patches, mostly in the ileum, not anywhere else. Usually it can be other places, but it's mostly in the ileum. Goblet cells, here's a little test. So as you can see here, these goblet cells, they're getting more and more towards wherever this is going. So what would you think the first one is? Duodenum, right? Because you don't need to secrete that much mucus. And then jejunum, and then the jejunum is kind of like, it doesn't have that many goblet cells, but not that little. And then the ileum, the most goblet cells, because it needs as I said before, the villi get more like deep and thinner, and it's more about intestinal immunity and secreting mucus rather, and like alkalining the pH and whatnot, rather than digestion, which is what the duodenum is mostly for. Okay, and then plique, it's mostly in the what did I say? Yeah, jejunum. Because why? The jejunum is most important for absorption, and the plique allow for a lot of absorption. Okay, now time to discuss the pancreas. The pancreas is pretty simple. It has a head, a body, a tail, and I'll explain what, consists of it. Now, the thing about, remember when we talked about exocrine glands in the stomach? In the salivary glands. Now, the thing about the pancreas is they have something called centroacinar cells. And all that is that inside of the acinar over here that are already excreting whatever it needs to excrete, there's something, it's just another cell. And all it does is just it extends outside and it just connects to the intercalated ducts. So as soon as you hear centroacinar, think pancreas exocrine ducts. Okay? And so over here, these would be the acinar cells, and then these would be the centroacinar cells, and this would be the intercalating ducts. As we know before, intercalating ducts go into striated, and then, main ducts, interlobule, all of that. Anyways, so in exocrine, there's as we said before, there was enterocrine glands, and over here it secretes two things that are kind of important: secretin and CCK. Now, think about it. Actually, you can't, I'm just going to explain. But acidic chyme, as soon as the duodenum feels the acidity of the stomach, it secretes secretin. And secretin, what it does is it just acts on the pancreatic duct cells over here to dump bicarb and potassium to, increase the pH. I keep messing that up. Increase the pH. And that's basically what secretin does. You know more about this in physiology, but CCK is released when what's it called? When the duodenum feels fat and protein entering. And the CCK is mostly to dissolve fat and protein. And so it releases digestive enzymes from the duodenum. And the acini here, the simple columnar of the intercalated cells, we know this. Okay. And so for the pancreas, it's divided into lobules. And these lobules are called, or they have lobules, and there are things like areas that are dispersed within the lobules, and they're called islets of Langerhans. What are islets of Langerhans? They're actually very, very important, and they play such an important role, but they're so, so tiny. Like, look at them. That's so funny. Anyways, so the islets of Langerhans are made up of a couple of cells that are so important. There's alpha cells. Alpha cells are they produce glucagon. And glucagon, as what's it called? As you would know, inshallah, and endorebro, is that it increases your blood glucose level. Now, beta cells, and they make up most of the Langerhans cells, and they're also mostly in the middle, while alpha cells are more on the sides. But beta cells, they secrete insulin, and everyone knows that insulin is meant to lower glucose levels, so you give them to diabetics. Now, D delta cells, they're used for somatostatin. If you took physiology, you would know that. I personally, and then there's PP cells, and they're kind of sparse. But yeah, so inside of an islet of Langerhans, there's the alpha, beta, and delta, and PP cell. And in the alpha, what does it secrete? Glucagon, beta, insulin, and delta, somatostatin. Amazing. we're done with the third lecture. Now, what is the name of the small intestine cells that play an essential role in immunity? Paneth cells. Exactly. You have two slides of tissue, duodenum and ileum. Which distinguishes the duodenum? Brunner's glands. This is so important. It's only for the duodenum. Myenteric plus, what does that have to do with it? Auerbach's plexus. It's in everywhere in the GI between muscularis and externus and Peyer's patches. It's not specific to duodenum. Bilhaks, it's actually more in the ileum. Okay, in the crypts of Lieberkühn, cells have a strongly eosinophilic stain, apex, and basophilic stain. What is the structure around the nucleus? This is just basic histology, but if you can go before, they're talking about Paneth cells, by the way. This is what they're talking about because in the crypts of Lieberkühn at the end, there's Paneth cells, and they're very high in rough endoplasmic reticulum. I think I wrote it down, but yeah. Okay, now, Bismillah, we can start with the large intestine. And the large intestine looks a little bit like this. We're going to talk about the appendix and the rectum as well. Now, the large intestine, it's mostly used to get any electrolyte or water outside of the chyme or whatever comes out of the small intestine to form a solid stool in which you're going to propel down through the colon into the rectum and, out as waste. And it's also very, very heavily involved in lymphatics and immunity. So you're going to see a lot of gut-associated lymphoid tissue over there because, as I said before, it literally ferments bacteria. Okay, and it's a breeding ground for bacteria. So just remember that. As well as mucus, it produces a lot of mucus because you're trying to make solid stool, and to let it, go down nice and smooth, you have to produce a lot of mucus to get it there. Anyways, so as you can see, the large intestine is a little bit different to the small intestine because there is no villi. There's no villi. It's not the same, but there still is, like an epithelial lining of microvilli and whatnot to allow for absorption. However, it's not that heavily involved in absorption. But something that we can notice that is very, very obvious is that there's so many goblet cells. There's so many goblet cells all over here. Okay. Now, as you can see over here, it's usually straight tubular glands. These are glands, so they secrete, mucus, as I said before. And once again, there's crypts of Lieberkühn, and, people say that it looks like a rack of test tubes because, by the way, these crypts reach all the way down to the muscularis mucosa. So while before it wasn't reaching to the muscularis mucosa, the crypts were reaching to the no, they were reaching into the muscularis mucosa. Anyways, they are perpendicular to the muscular. Okay, so these are straight tubular glands. As I said before, they secrete mucus. And these crypts of Lieberkühn are deeper because they reach the full thickness of the mucosa. Okay? The full thickness. And yeah. And these are all perpendicular to the muscularis mucosa over here. So they reach all the way down here. Unlike the other crypts, they would kind of not reach that far or they wouldn't be that deep. And it kind of looks like a rack of test tubes. Anyways, this is what the large intestine looks like. And as you can see here, as I said, there's no villi, but they don't have plicae circularis, but they do have something called semilunar folds. And this is what you can see over here. They're not like sticking out to increase surface area because, like I said, it's not the main function of the large intestine to be able to absorb everything. It's just to keep the feces moving and also to absorb, water and electrolytes and everything. But yeah, there's no villi, but there are microvilli. And a thing over here is that there's so many goblet cells, and there's all the same kinds of cells. Like as I said before, there's yeah, except for Paneth cells. So there's no Paneth cells, as you can see here at the end of the, wait, hold on. Yeah, at the end of the crypts over here, there's no Paneth cells. They were really like bright pink and they had granules because the colon isn't necessarily trying to protect from bacteria because it's literally colonizing bacteria. Okay. Yeah. Anyways, so as you get closer to the rectum, there's more mucus secretion and less like need to absorb because you're getting ready to propel the waste. You don't need to absorb anything else. Anyways, so for the epithelium, it's enterocytes with microvilli, just like before, and also goblet cells that produce a lot of mucin. As we said, it's very, very important. And then for the lamina propria, as we said, it has a lot of gut associated lymph tissue. Um, and for the submucosa, like I said, Meissner's plexus all throughout, all throughout. Okay, now this is so important, and I wish I put a star here, but I didn't. But let it be known, I'm going to put a star afterwards before uploading this, but there is a star here. It's so important. But in the large intestine, and it's so obvious when you dissect, I don't know if you guys, you probably went to lab and saw this, but these are called tinea coli. And what happens, now we're in the muscularis externa, okay? And you have the outer and inner muscular layers. And so here's the inner. So this is the circular layer, just like everywhere else. And this is the outer, the longitudinal layer. However, in certain parts over here, like let's pretend that this is the muscularis externa, and this is the inner part. So this is the circular part, and this is the longitudinal part. In certain areas, it thickens a lot. And what happens is it scrunches up the what's it called? It scrunches everything up and it creates something called hostra. And the hostra is just used to propel the feces. Because like you don't want the colon or yeah, you don't want the colon to be super long and super extensive like the small intestine. The point isn't to absorb, it's to propel and to move and to push, and you're putting mucosa and you're trying to push it out. And yeah. Okay. And then the appendix. The appendix is a lymphatic organ. And this is so easy. Like once you see this, because there's such obvious like follicles, like lymphatic nodules, it's so obvious. So once you see this, you know you're in the appendix. Also, it's lined by simple columnar. And yeah, it's also a visceral peritoneal like organ. So outside, it's going to be mesothelium. Okay. Yeah, as you can see over here, mesothelium lining it. And yeah, I think that's all you really need to know about the appendix. Okay, now about the rectum. Now, the rectum, there isn't much to say about it. I'm going to talk about it more here, but these are called columns of Morgani. This is the rectum, and these are the folds, and you learn more about it in anatomy. And this is like the dentate line or the Z line or something. Not, yeah, Z, yeah, the Z line. I can't remember if it's Z line, honestly. But yeah. Okay, so the rectum has simple columnar, just like the rest of the colon, and it lacks villi. Why? Because you don't need to absorb. And also the glands are longer. Why? Whenever the glands are longer, that means they're producing more, secretory zymogens or whatever, the mucus that we talked about, and also adventitia, because the rectum, it's not like you need it to hold in place. You need the rectum to hold in place inside or like on the edges. So that's why there's adventitia instead of serosa or anything like that. Anyways, also, just like the pyloric sphincter, the circular layer thickens to form the sphincter, just like it's normal. Any sphincter that needs to be like created or transitioned into, that's when the circular part or the musculus externa, thickens a lot. And you can see this right over here. Like this is the whole circular muscle from the muscularis externa. Oh, and also the end of it, this is striated muscle. And so it's completely voluntary. Alhamdulillah, we have the ability to defecate when we want. Okay. Yeah, and the important thing about this is that there's something as well. You know how we talked about the gastroesophageal junction? There's also something called the rectoanal junction. And this is just as soon as the sphincter begins to thicken, and you can tell the difference. Like this is what's it called? This is the projections, this is the epithelium, the mucosa, and then you move on and boom. Now this is the rectum. So this is the rectum and this is the anus. And yeah. Okay, let's get some questions out there. Folds of tinea coli facilitate hostra segmentation by working on which of the following layers? Muscularis externa, exactly. It doesn't work on muscularis mucosa. It's not going to get much done if it's in the mucosa. Submucosa, no. All we know about submucosa is that it has the Meissner's plexus. Yeah. And then lamina propria. Awesome. Okay. Anyways, you are invited to shadow a GI pathologist. A surgical specimen is examined using a double-headed microscope. This normal tissue is obtained from which of the following locations in the GI tract? the recto-anal junction. As you can see here, it looks quite similar. Like it's more, projections, and then it goes into like the anal canal so it can excrete the feces. And we honestly didn't talk about any other junction. We didn't talk about the colorectal, gastroduodenal, no, all of this. This is more relevant to what we're studying. And also there's so much, as you can see over here, there's so much like mucosal glands or goblet cells. Okay. Now, your classmate opens a new digital slide and you study it together on the computer monitor. Identify the segment of the GI tract. You don't even need to think about it twice. As soon as you see all this extensive lymphoid nodules, you know it's the appendix. You're in the appendix. It doesn't matter. I hope it's obvious. Okay, Bismillah. Last stretch. This is the liver and biliary apparatus section. Now let's start with explaining what the liver is. Now the liver is a gigantic organ on the right side of your body. It's split up into lobes, and also part of it, or the gallbladder is kind of like not a part of the liver, but it kind of sticks to the liver, and I'll explain what the point of it is right now. Anyways, there's hepatic veins all throughout the liver, and this is really important. Why? I'll tell you right now. There's also hepatic arteries. Now, the liver it doesn't have any of this like mucosa, submucosa. It doesn't have that. It's all parenchyma. Now, parenchyma means working tissue. And that's really special because it's split up into these tiny little hexagons. And these hexagons, they formulate a shape. Anyways, outlining the liver, there's something called Glison's capsule. It's a capsule, basically. It just holds in all the liver, and this is kind of important. Anyways, what did I want to say over here? Let's take this and let's put it over here. These lobules in the liver, this is what they're made up of. So typically there would be a gigantic central portal vein here. There would be a gigantic central portal vein, and then there would be something called the portal triad over here. The green thing over here would be the bile duct, and then the red thing would be the hepatic artery, and then the blue thing would be the portal vein that I just talked about. And they spread out all throughout this. Why? So the liver its main purpose is to detoxify. And so it's constantly giving out and taking in and giving out and taking in blood, giving it out through the veins, taking in blood. That's what's happening right now, okay? And so it sets up a very huge, very complex little system. And these little tiny things, these are called sinusoids. And sinusoids are another kind of capillary, but in the liver. They're basically just a combination of the vein and blood, and this is where all the exchange happens, okay? Now, over here, this is a histology slide. This is the portal vein. It's humongous. It's humongous in the center. And then this is the artery, and then this is the bile duct. Okay, now this is pretty important. Okay, the portal triad is pretty important, but this is also it on histology. So central vein, and then these are at the corners. Now, okay, so sinusoids, like I said, they're meant for diffusion. Now, they're capillaries, so they're meant for diffusion. And there's also Kupffer cells. Now, macrophages, when they're in the blood, they are called macrophages. However, when they go into tissue, they turn into Kupffer cells, and they have many names all throughout the body. In the liver, they're called Kupffer cells. So Kupffer cells are very unique to the liver. Macrophages anywhere else would be called something else. Now, flattened endothelial cells, obviously, sinusoids need to have flattened endothelial cells because why? Because they need to have exchange. And Kupffer cells, to make sure that everything, like immunity-wise, a lot of blood comes in, and there could be some sort of pathogen or anything. And so Kupffer cells are there for immunity. And then they merge together and they do anastomosis, they mix together and whatnot. And there's discontinuous endothelium and basal lamina also for diffusion of like any kind of molecular micronutrients or whatever. Anyways, the lobules. So this is kind of how it looks like. I showed you like a 2D image of it like this. However, imagine like a bunch of them stacked on top of each other. This is what the liver is. And this is why it's so dense. The liver is so dense and so heavy because this is what's going on. These tiny little squares, these are called hepatocytes. Now, hepato means liver and cytes just means cell. And so between these hepatocytes, these are the little sinusoids we talked about, right? And this is where all the exchange happens between the hepatocytes and the sinusoids. Liver, okay, what produces bile? Don't say the gallbladder. The gallbladder stores bile. The liver cells, which are hepatocytes, they produce bile, and then they're stored in the gallbladder, okay? And so what happens is that, the blood comes in, it detoxifies, and it sends it out through the portal vein. And also it sends out bile through the bile duct away from the way that the blood is coming. It comes in the opposite direction. Okay. And there's also a space over here. We'll get into it later, but it's called the space of Dees or dice or something. And it's between the sinusoid and the hepatocytes. And the hepatocytes have little microvilli to also further, um, increase surface area of secreting into the sinusoid. Okay. All right. Now the hepatocytes, like I said before, this is pretty important, but the hepatocytes are like lined up like this, and they have microvilli, and they put stuff into the space of Dice, and then this goes into the sinusoids and exchanges and whatnot, and this is how this happens. And there's also something called stellate cells. We'll explain it in a bit. But yeah, these are the Kupffer cells that like line the sinusoids, which are pretty important. Sinusoids are made up of flat endothelium, which is this, and Kupffer cells for the sake of like detoxifying blood once again. Okay, hepatocytes, like I talked about, they're kind of like they're polygons, just like the lobules, and they basically make up the entire liver, like 80% of the liver. And they have a really, really dark nucleus and kind of like a foamy cytoplasm because of the glycogen deposits that they have in the liver. And it's also um, whenever you hear about transplants, you hear about liver transplants. Why? Because liver, subhanAllah, subhanAllah, the liver cells have the potential to regenerate, and that is insane. And because they have the potential to regenerate, their lifespan is really, really long, subhanAllah. Okay, and the space of dice or whatever we talked about, it's predominantly type 3 collagen. Now, I don't know how important that is. That's not really, I think the fact that there is a space that allows the hepatocytes to exchange with the sinusoids is really important. But the most important thing out of all of this, and that's why there's a gigantic star, is stellate cells. Stellate cells are there to it's more okay, what's relevant is that when the liver undergoes damage, which is called cirrhosis. So sometimes you hear like, oh, liver cirrhosis, it's damage or scarring of the liver. These are the cells that are primarily in charge of it. They're called stellate or Ito cells. Okay? Now, there's bile flow. I talked about how hepatocytes can produce bile, but how does it go there? There's these tiny little bile caniculi, and when it's producing the bile, it goes into these bile caniculi. And so it starts out over here, and it goes through the canal of Herring, right over here. This is the canal of Herring, and then it goes into the bile duct. And so it goes from bile caniculi to canal of Herring to bile duct. Okay? That's all you need to go. And it goes opposite to the blood flow. All right? Now, I just wanted to put this, it's really important, this concept, by the way, and I just wanted to put this in relationship to like how the bile gets collected. So it's going through all these bile ducts, going all the way over here into the gallbladder where it's stored, or it can go into the common bile duct where it's produced or like dumped into the duodenum, like we know, and mixed with pancreatic enzymes. Anyways, now bile ducts, just like any other ducts or most other ducts, once you get to the point where they're associated with the gallbladder, they're called cholangiocytes. And choline is like the suffix, or not the suffix, the prefix for the word gallbladder. And they're cuboidal in shape. Now, you don't really need to go into detail. This is mostly physiology, but this is the histology part of it. Anyways, to why the liver is so dense and so, structurally integral, if that's even a word, is because there's reticulin between the hepatocytes. And all you really need to know is that it's like a mesh of the ESM and it's type 3 collagen. Just like what was type 3 collagen? The space of dice or whatever it's called. Okay, all respect. Okay, I feel like people like scientists, they just find like the most simplest parts of an organ and they name it after them because if you didn't notice, it's like space of dice and then like canal of herring and it's just a bunch of people naming things after themselves. But it's okay because it's your job to learn it. Anyways, there's types of lobes, but not actual like physical types of lobes. This is just more important when it comes to classifying things clinically. Now, there's the classic kind of lobe that we talked about before. It's in a hexagon and there's a central vein and there's portal triads between it. And this is more about like, yeah, it's centered around the central vein. And that's all you really need to know. And then there's portal lobule. Okay, this is classic lobule. I forgot to mention that, but this is classic lobule. Portal lobule, it's shaped like a triangle. That was shaped like a hexagon and it's centered around the portal triad, right? This portal triad. It's centered in the like cross angular thingy. And it's more about bile secretion, like where the bile is pointed towards. And then liver acinus, it's more of a complex one, but it's just talking about, it makes like an oval shape. It goes from portal triad to portal triad. And so there's zone one, zone two, zone three. And so one zone would be really close to the blood supply, so the artery supply. And then one zone would be really close to the central vein. And so one would be really close to blood and oxygen, and one would be really close to, less oxygen in the venous supply. And it's like a diamond. And you don't really need to know why this is clinically important, but this is just clinically important to classify like how you want to think about the lobes of the liver. Anyways, gallbladder. Now the gallbladder, it's meant to store bile. That is what the gallbladder does. And the epithelium is just simple columnar. It looks like this. But the very important thing about the gallbladder, this is so important. And this is something that we didn't like even mention the entire GI, but this is so characteristic. It lacks a muscularis mucosa and a submucosa. So as soon as you see lamina propria and you don't see any kind of muscular layer or anything like that, and you immediately goes onto the muscularis, that is the gallbladder. So you know where you are. And it like kind of branches and stuff. Anyways, yeah. And there's something called Rokitansky-Ashkoff sinuses. And these are like, they're little punch holes. They're not actual punch holes. It's just because the histo slide, when you cut it, it looks like it's punch holes. But actually, what you're looking at are these like sinuses. And it's just used for like increased space and to like distend. But that's what they're called. Okay. Oh my God, we're done. Which of the following is found at the center of the portal lobule? Portal triad. This is the one that is the triangle. What is the central, or what is the classic lobule? Hexagon. In the middle of it is the central vein. Okay? Bile caniculi and bile ductules are connected by, yes, not hopes and prayers, canals of Herring. A 68-year-old alcoholic male developed liver cirrhosis, which characterized by bands of scar tissue. Now, which of the following cells was most likely involved in that process? Okay, so you may not know what this word is. Lipocytes are another word for Ito cells, which is another word for stellate cells. I know it's really annoying, but you can just do this by elimination. Kupffer cells have nothing to do with liver cirrhosis. Hepatocytes, nothing to do with liver cirrhosis. Endothelial lining cells, what does that even mean? That's so vague. And cholangiocytes isn't even involved in the liver. So, yeah, that's why it's lipocytes. In the laboratory, there are two slides of tissues, gallbladder and stomach. Which is the difference between the two slides with respect to the gallbladder? What did we say? It has no submucosal layer and no muscularis mucosa. Or muscularis mucosa. And with that, I'm done. Thank you so much. I hope you guys really benefited from this. And inshallah, I wish you all the best on your exam. Please scan this barcode. There's a quiz, and I think it would really help because it has a lot of the high yield stuff that I talked about. But yeah, I'd really appreciate the feedback. And I never thought I'd do a histo pal. Thank you guys, and have a good night or morning or whenever you're listening to this.